Hello, let's talk about T-cell neoplasms. This SDL has four subheadings, which correspond to four different groups of T-cell neoplasms as defined by the World Health Organization. So these four groups have four very different primary presentations, which is why they're individual groups. First, there's nodal T-cell neoplasms. We say nodal as in a lymph node, and these like to present with generalized lymphadenopathies. Now that just means a swollen lymph node, and if it's generalized, that means there are many swollen lymph nodes. So perhaps there's one behind the knee, and then a couple under the armpit, then a couple under the other armpit, and a supraclavicular one, and then a postauricular lymph node, like 8 swollen lymph nodes. That's generalized lymphadenopathy. And in the setting of cancer, these lymph nodes are non-tender. They do not hurt. And that's going to differentiate a cancer, specifically a lymphoma most commonly, but often leukemias can present nodally, or even primary cancers of an organ can metastasize to a lymph node. So if you press on the lymph node and it doesn't hurt, you should be very suspicious of cancer, because if it is an inflammatory process, inflammation produces ischemia, and tissue ischemia always hurts. So one swollen lymph node, especially in the neck and above, you're thinking an infection. But many swollen lymph nodes, if it's a generalized painful lymphadenopathy, then you're going to have systemic diseases very high in your differential. Things like SLE, systemic lupus, is a classic example of what could cause you to have multiple swollen lymph nodes. Other autoimmunities, such as rheumatoid arthritis, are up there as well. So that's our first class of T-cell cancers, those that present with a diffuse non-tender lymphadenopathy. And then we've got one little subclassification of T-cell cancers, and NK cells are involved in this umbrella. They're under this umbrella of T-cell cancers as well. And we've got an extranodal nasal type NK or T-cell lymphoma. And so this is a really easy one. It's going to present in the nose, otherwise it wouldn't be called nasal type. You think you're going to get a nasal type lymphoma down in your knee, or on your hip? No way, impossible. So this one presents right there, pretty dead ringer giveaway. Then we've got a third class of T-cell neoplasms called the cutaneous T-cell neoplasms. That's exactly what it sounds like. These are going to present with a skin rash. And now we have two of them here, but really it's one disease. Let me tell you the difference between them real quick. In mycosis fungoides, you just have a skin rash, and you've got these big, large, often red erythematous plaques. And if you biopsy it, you'll see lots of clonal T cells inside those plaques. And the fact that they're clonal when you stain them means that it's cancer. They're all the exact same cell. And then if you take a blood smear and you don't see any clonal T cells on peripheral smear, you're dealing with mycosis fungoides. However, if you take a peripheral smear and you see clonal T cells all in the bloodstream, you're dealing with Sezary syndrome. It's just some dude named Sezary diagnosed mycosis fungoides and saw that it was a little bit of a variant with some T cells in the bloodstream. And he said, hey, I could probably get something named after myself right now. And that's what happened. So mycosis fungoides and Sezary syndrome are the same exact thing, except in one of them, you see T cells in the blood. In MF, you do not. And then finally, we have a couple of leukemic T-cell neoplasms. And up to this point in the SDL, you deal with lymphomas, which present as basically a cancer of the lymph nodes. But a leukemia is, in general terms, a cancer of the blood and bone marrow. And so patients with a leukemia most often present with blood dyscrasias. They're going to have a pancytopenia, or maybe an anemia, or a thrombocytopenia, because the cancer is proliferating in the bone marrow. Or maybe they'll have an elevated white count, leukocytosis peripherally, because again, it's a cancer. It's a clonal proliferation of white cells, in this case T cells. So T cells could be drastically elevated in the blood. That's going to give you the diagnostic clue when you get that blood count and you see elevated lymphocytes, lets you know some sort of leukemic presentation rather than a lymphoma might be going on. And also patients with leukemia, this one symptom of easy bruising, I'll have to do a little bit more research in that, report back later, but that does seem to be pretty common to leukemic presentations rather than lymphomas. So that's the 4 classes of different T cell cancers that we're dealing with. I'm going to give the big picture synopsis, and then we'll get into the specific cancer types. Here's a slide that I made that selectively picked out things specific to each cancer. So really, we've got 7 different cancers in this SDL, 8 if you want to count mycosis fungoides and Sezary syndrome as different things. Let me tell you how they all present with things particular to them. PCTL-NOS, the NOS stands for something like no other symptoms, or what does that stand for? Not otherwise specified, right? So that's the one that you're going to fall back on if you can't put a label on whatever you're seeing. If there's no specific blood markers, then you're going to fall back on its primary T cell lymphoma with no otherwise, I can never remember that, not otherwise specified. There we go. So then we've got AITL, which stands for angioimmunoblastic T cell lymphoma. So this sucker likes to grow around blood vessels. It's angioimmunoblastic. Angio, blood vessel, immuno, white cells, blastic, growing. So you always find it around blood vessels on biopsies, and it stains for 3 cluster of differentiation markers that none of the other cancers in this SDL stain for, and those are going to be CD10, CD21, and CD23. So if you get a question and the cancer's got positivity for one or multiple of those 3 clusters of differentiation, you know you're dealing with the angioimmunoblastic T cell lymphoma. Then we've got ALCL, which is anaplastic large cell lymphoma. And I remember that one because anytime I see anaplastic, you know, that cancer is a bad dude. That cancer is a villain. It's very dedifferentiated. It's very aggressive. So the anaplastic large cell lymphoma has a couple things in its corner that none of these other T cell cancers do. It's got CD30 positivity, the only cancer in this SDL, it's going to stain positive for CD30. And it's also got this translocation between the 2nd and the 5th chromosome in which the ALK gene gets rearranged. And that's the same gene that gets rearranged in adenocarcinomas of the lungs. And so they really want you to know what that gene does. We'll cover that when we talk about, actually, no, forget that. I'll go look at it right now. We'll find out what that ALK gene does. Because again, they love asking you about, well, the gene product of this cancer participates in blank, and then they'll give you the pathway. And so for that angioimmunoblastic one, for example, it's a GTPase. So that's something they could ask you about there. And that's really the only things in these sections worth highlighting, because you know that's where they want to ask the questions from. So with the anaplastic large cell lymphoma, ALK is a membrane-bound tyrosine kinase. And that's exactly it. That's how they would ask the question. They would say, they'd give you the presentation for the anaplastic large cell lymphoma. They'd tell you it's got a translocation, or maybe they'd say it's CD30 positive. And then the question is going to be the protein that's out or mutated in this cancer codes for blank. And then A, tyrosine kinase, you know, B, growth factor, C, growth factor receptor, D, like cell cycle checkpoint protein. And so that's the question essentially. And you can take that question and insert any cancer in the world into that question frame. So that's why it's a popular question. It's easy for test writers. So that is our anaplastic large cell lymphoma. Then we've got the ENKL, and that's our extranodal NK cell lymphoma. Can be a T cell one too. What I want to point out to you is that anytime you see CD56 positivity, that means it is particularly an NK cell cancer, and there's only 2 cancers in this SDL that would present potentially with CD56 positivity. That's that extranodal one that presents in the nose. And then that's also this LGL one. That's the very last one in the whole SDL. So those 2 are NK cell cancers that express CD56 on their cell surface. Only 2 in the whole text that are going to express that CD56. Then you've got mycosis fungoides and Sezary syndrome. And again, those are the 2 that present with a skin rash, big plaques like psoriasis, but without the shininess, big elevated plaques. They're red. Again, you biopsy them, you see T cells. And then what's step number 2? You get a blood smear. And so if there are clonal T cells in the blood smear, it's Sezary syndrome. If there aren't, they're only in the skin. It's mycosis fungoides. Then we've got ATLL, which stands for adult T-cell leukemia and lymphoma. So this one's associated with HTLV, human T lymphotropic virus, and there's a very strong association between that virus and this adult T-cell leukemia lymphoma. In fact, 1 out of 20 people who get that virus get this cancer. Now, from what I've seen in first aid, pathoma, they don't really care about if you know what the virus does because it is a very rare virus. They care about, do you know what kind of cancer arises from infection with that HTLV1 virus? And it's this, adult T-cell leukemia. So the virus gets into your T cells, messes them up, initiates clonal proliferation of T cells. There's your cancer. And what's particular to this post-infectious T-cell leukemia is going to be these things called flower cells that look like 4-leaf clovers. And here they are in color. Very pretty. And that sort of histology is particular to this cancer. It's got an endemic presentation in parts of Asia, Africa, South America, around the equator. Then the last one that I have on this list is going to be the LGL, and that abbreviation stands for large granular lymphocyte leukemia. So these are CD8 T cells, and this is a leukemia, again, not a lymphoma. So that's already gonna, if you see some leukemic symptoms, that narrows down the cancers in this SDL. It could be 2 possible things, essentially. There are 2 leukemias here. One of them is that one associated with the virus. The other one is this one. And so what are leukemic symptoms? Again, blood dyscrasias. There's a cytopenia. There's a high white count, really high white count. But specifically that thrombocytopenia or anemia, very common presenting symptoms of these leukemias. And so with the LGL leukemia, a couple things particular to it that you do not see in any other cancer in this SDL is going to be the CD8 for those Th1 T cells. It's a Th1 cancer. And also it's one of 2 in this SDL that it could potentially express that NK cell CD56 positivity. So that's the long and short of what sets these cancers apart from one another. Now let's go to the SDL and take it a little bit more slowly, a little bit more of a fine-tooth comb through them one at a time. We begin with the peripheral T-cell lymphoma, not otherwise specified. You know, it doesn't have a type. And T-cell lymphomas do tend to present in the adult and elderly. Very rare that you see a child with a T-cell lymphoma. Now, presenting symptoms, and this paragraph really is going to apply to any lymphoma. You see generalized lymphadenopathy. Again, that's painless, non-tender. The skin and GI tract are commonly involved extranodal sites. That means you could start seeing T-cell proliferation in a little cluster outside of a lymph node. So even though it's a lymphoma, it's a cancer of the lymph nodes, it can still go elsewhere in the body. Now, within the GI tract, you know, there's a ton of lymph nodes in the small bowel, and then in the stomach too. That's a very common site for extranodal malignancies. In fact, I think like 10% of gastric tumors are going to be maltomas, lymphoid tumors, right? So then we talk about systemic B symptoms. And SDL tells us that B symptoms are fever, night sweats, weight loss, and that 1/3 of all patients with this not otherwise specified lymphoma present with B symptoms. Now, it's important to know what systemic B symptoms are because they will pop up in other lymphomas. So the B symptoms are part of the Ann Arbor lymphoma staging criteria, which separates patients into A or B based on the presence or absence of systemic symptoms. Now, these dudes are smart. They said A is going to stand for absence of symptoms. And so that's really easy to remember. And then if you have B symptoms, you have the symptoms. So A, no symptoms. B, symptoms. And what are the symptoms we're talking about? Again, fever, night sweats, weight loss. I want to take this moment to pause and remind you that tuberculosis is an infectious disease that can cause fever and night sweats and weight loss. So if you get a patient who is presenting to you with those systemic B symptoms, you might want to work up tuberculosis as well before you jump to, oh, what white cell cancer is this, you know? So when you go to biopsy a lymph node, because if a patient's got a big lymphadenopathy, that's a great idea. Take a needle, fine needle aspiration, and you're going to look at it, and it's going to have a lot of white cells in it if it is, well, no matter what it is, really, because even if it's infectious, white cells will be popping off in there. But in a tumor, you will see eradication of the normal architecture of the lymph node. And so knowing what the normal architecture of the lymph node is, that's a pretty handy thing to have on file. Remember, you've got follicles of B cells with germinal centers, and those are only B cells. And then around those little spheroid follicles, we've got a paracortex, which is going to be T cell territory. Only T cells live in the paracortex. And then the closer you move to the efferent lymphatics, right? The closer you move to the efferents, the more often you start seeing macrophages, which are just antigen presenting cells of the lymph node. So that's really the three classes of immune cells we have in the lymph node. We have B cells in follicles, we have T cells in paracortical territory, and then we have macrophages as you move to the hilum of the lymph node. And then surrounding all of that, you've got a trabeculae, which is just epithelial cells. So that's your lymph node anatomy, and it's going to be messed up in a cancer. An inflammatory background is frequent. And what does inflammatory background mean? Well, inflammation is just an appropriate immune response to something. So picture a lot of B cells and macrophages and maybe some activated plasma cells making IG, and then maybe some eosinophils as well, degranulating. That's an inflammatory milieu. Now, skin involvement is somewhat frequent in any T cell cancer because these are migratory cells. They're circulating cells. They're white cells. They fly all over your body in your bloodstream, and they attach wherever there's inflammation. Endothelial cells express attachment proteins, those CAMs, cell adhesion molecules, right? And then the T cells just extravasate and get into some tissue, and they find the bad guy and they take them out. That's a T cell and an NK cell's lifestyle. So that's how you can see skin involvement in any T cell cancer. Now we start talking about immunotyping. That's the pathologist's job. Drop some potions onto a slide and see what sticks. Now, because it's a T cell cancer, it'll stain positive for CD2, 3, 5, and 7. And CD4 versus 8 is going to depend on how differentiated the cancer is. Most of these T cell cancers express CD4, and then the one at the very bottom of the list, the large granular leukemia, that can stain CD8 positive. Don't forget that. Now, these tumors don't express B cell associated antigens, and so the way I remember it is if it's divisible by 5 and it's kind of a low number, it's on a B cell. So 5, 10, 15, 20, all of those are on B cells. Those are B cell antigens. Those will come up again in our different lymphomas and leukemia, our non-Hodgkin's lymphomas especially. Now, put a star next to this. Epstein-Barr virus, our friend human herpes virus 4, is detected in up to 50% of cases of this not otherwise specified peripheral T cell lymphoma. Does that make sense to you? It should. because Epstein-Barr virus is going to infect lymphoid cells. So that's that not otherwise specified. Again, refer back to the review slide where everything is consolidated. And if you know this stuff, and if they give you cancer and it doesn't have any of this, then you're just going to go with it ain't got no type. Now the angioimmunoblastic T-cell lymphoma, love this one. They tell you exactly what it is. It's going to be white cells proliferating around a blood vessel. Median age of presentation 60 to 65. The vast majority of patients present with advanced disease. What's the doctor way to say it? Proliferation of arborizing high endothelial venules. Okay. Surrounded by a CD21 positive follicular dendritic cell and thick basement membranes. So this one stains CD21, CD10, CD23 as well. Yep, so we got those on there. CD10, 21, and 23. A lot of different clusters of differentiation that this one picks up that the others in this SDL do not. And then this whole angioimmunoblastic one is characterized by mutations in the RHOA gene, the Real Housewives of Atlanta. And so that's, if it's in 70% of them, you know, that's a classic presentation. It might as well be in all of them as far as board style questions are concerned. And it's due to a mutation in a GTPase. That RHOA gene controls a GTPase. And so you see ACE, that means it cuts something, right? And so GTPase, it cuts GTP. So when would that ever matter? In G proteins, come on, come on. Block 1, like undergraduate, you know, what's a G protein? Okay, it's this thing that has an on-off switch, and the on is GTP and the off is GDP. And it's always stuck to a subunit of the extracellular protein. You know, it goes through the membrane, then it's got an intracellular domain, which is stuck again to either GTP, which means it's on, or GDP, which means it's off. So a GTPase cuts off GTP from a G protein so that GDP might just bind again to that protein. And so it's off until it gets bound and activated again. That's a G protein. So if you have a problem with your GTPase, you can't cut GTP off of the G protein. So it stays constitutively activated. And in this case, T-cell receptor is GTP activated. So that's how it just stays turned on. Leads to cancer. Again, around the blood vessels. CD10, 21, 23. Not bad. Anaplastic large cell lymphoma. This is a bad cancer. We got a 2,5 translocation with ALK, which is a tyrosine kinase receptor. Rapidly progressive adenopathy. Again, those B symptoms of fever, night sweats, and weight loss. Don't forget to get a TB skin test. And you've got a characteristic histology with this one particular anaplastic lymphoma. You've also got CD30 positivity. So they're going to ask you what you would see on histology, or they're going to say what would it stain positive for, or they'll say what gene is out, or what does the protein do that the gene codes for. That's about all they could ask you. Maybe if you're lucky, they give you the first order and they say, what's the diagnosis, you know? So let's look at the histology and put a nail in anaplastic large cell lymphoma. You see kidney-shaped nuclei. And yeah, straight up, I mean, that looks like a kidney right there. Bean, it's a bean-shaped nucleus. And kind of got to look close to see them. If you were to just get rid of the annotations on this slide. Don't know why that's not doing that. But if you were to get rid of the annotations, then, you know, you kind of got to look closely to see the bean-shaped nuclei, but you look closely and there they are. So that's the hallmark of anaplastic large cell lymphoma. Extranodal NKT cell lymphoma, nasal type. All right. So most frequently seen in Asia, native populations of Central and South America might be important. Here's the money shot. Nasal NKT cell lymphomas arise in the nasal cavity, nasopharynx, or upper aerodigestive tract, causing progressive destruction and ulcerative lesions or obstructive symptoms due to mass lesions. That's basically all you need to know about this thing. And then CD56 positive. What cell expresses CD56? The NK cell. And you might want to know it's got an angiocentric distribution, just in case they ask, what would it look like under a microscope? And you might want to know that half of these dudes have a chromosome 6q deletion, just in case they ask you, what's the genetic abnormality? And finally, something that I just picked up that I didn't see before is that there is a near consistent association with Epstein-Barr virus, suggesting an important role of the virus in the pathogenesis of this extranodal lymphoma. Other than that, there's not that much about this cancer in this text. So now we have our two cutaneous T-cell lymphomas. Again, MF and Sezary are the same exact cancer, but we're going to call them different things based on the degree of the spread of the cancer. If it's in the bloodstream, it's Sezary syndrome. If it's only on the skin and not in the bloodstream, we're going to call it mycosis fungoides. And likes to grow in scaly patches in sun-protected areas, interestingly enough. So like underneath your shirt in the groin area. And it is also associated with a generalized erythroderma, so red skin, erythro meaning red, diffuse erythema covering more than 90% of the body's surface area. So here's Sezary syndrome with an example of that diffuse erythroderma. Red skin covering just about this whole back. And if you look in the bloodstream in a patient with Sezary syndrome, you will find abnormal T cells. Contrast that with mycosis fungoides, in which you see T cells in the skin but not in the bloodstream. And in both MF and in Sezary syndrome, the T cells like to form these little micro abscesses, just little bubbles of T cells hold up alongside one another. A couple other examples here. And so the T cells will cause an inflammatory state in the skin they're localized to, which will lead to epidermal agitation and eventually scaly red plaques. So here's how they present. Again, notice it's typically parts of the body covered from the sun, so chest, the backs of the thighs here. And again, you see this in a test question. Next thing you're looking for is it in the blood or not? If it is, it's Sezary. If it's not, it's mycosis fungoides. What else could they ask you about this? What do patients die of? What are they at risk of? Sepsis. Why? Because their T cells are messed up. And because they've got a lot of skin ulcerations. And so the bacteria has a really easy access to hematogenous spread. That makes sense to me. It's nothing to do with the T cells, actually. It's because their skin just has continual lesions. Lymphadenopathy. Any lymphoma could present with lymphadenopathy. That's not saying much. Skin biopsies, medium to small atypical T cells with a cerebriform shape. Now, you're not going to see a cerebriform shape unless you are up on 40 times power. You know, you have to have a high magnification to be picking out individual T cell shape. But if you get asked, that's what you're going to see. You're going to see T cells with a cerebriform shape. You're also going to see microabscesses, which are just clusters of T cells in the epidermis. No special immunophenotype. It's a lifelong disorder. Sezary syndrome. I'm telling you, it's the same exact thing. Same cell markers, same skin findings, same rash. You just have cancer cells in the bloodstream. So we conclude this SDL by discussing a couple of T cell leukemias. First, there's that adult T cell leukemia lymphoma, which is endemic in several regions of the world, notably around the equator, and it's due to the prevalence of human T lymphotropic virus type 1 in these areas. You get the virus, you have a 1 in 20 shot of getting the subsequent T cell leukemia. It's an oncogenic retrovirus that is going to encode a TAX protein that stops infected T cells from carrying out apoptosis. So they are forced to stay alive. They are essentially immortal in some regards. So once that occurs, T cells proliferate due to the TAX protein activating the nuclear factor kappa beta and AKT pathways. Now, that goes on for long enough, all of a sudden you go from 10 to 50 to 500 to 5,000 identical copies of one T cell. So that's what's going on here. And your body might do a good job of repressing this and shutting it down, because CD8 cytotoxic T cells are your inherent anti-cancer mechanism. It's cell-to-cell, cell-mediated cytotoxicity, killing via perforin and granzyme, which, remember, perforin perforates, makes a hole, makes a tunnel, kind of like the membrane attack complex. And then what does granzyme do? Think about it. I know you can remember this. Granzyme gets inside an infected cell and activates the caspases, 3 and 8 and 9 and all that good stuff. And then calcium goes into the cell cytoplasm, messes up proteins, messes up ion channels, messes up membranes, etc. So that's how a cell dies when a CD8 cytotoxic T cell gets its hand on it. Now, sometimes the cytotoxic T response does not control this cancer. That's when you actually get the cancer. But most of the time, the cytotoxic response can shut it down. So there are several variants of this T cell leukemia. One of them might present with hypercalcemia due to lytic bone lesions. Another one might present with a rash, doubtful. That's only the one that's 60% of cases, which is the one you are most likely to get tested on, shows you a hypercalcemia and punched out bone on x-rays, kind of like a multiple myeloma would. And if they give you a blood smear and a question, you've got these flower cells, which again look like 4-leaf clovers. Very characteristic there. No particular immunophenotype, and you diagnose it based on serum antibodies to the virus that caused it all, HTLV1. So finally, let's discuss large granular lymphocyte leukemia. This is a leukemia, meaning it's technically a cancer of the blood and of the bone marrow and the cells that constitute blood and bone marrow, not of cells inside lymph nodes, although leukemia can spread to a lymph node or multiple lymph nodes. It doesn't originate there. It originates in the blood and bone marrow particularly, which is why it likes to present with some cytopenias. You see a cytopenia on this exam, you know you're dealing with a leukemia, not a lymphoma. So median age of onset, 60 years old, just like everything else in this SDL. And B symptoms may be present. Again, they're not A symptoms. A means absence of symptoms. What are B symptoms? Fever, night sweats, weight loss. Neutropenia is demonstrated in 85% of cases. That's a whole, I mean, that's a big fraction. So you get a patient, they're going to have neutropenia in a test question. And if you looked at peripheral smear, you're going to see large granular lymphocytes. And I think I got a couple of, I think I got that in color here. I do. It's the same thing as is in the SDL, just a little bit zoomed in. But you see just the little granules there. You can actually see them. Because normally lymphocytes do have a few granules, but they're going to be small, to where you can't even see them on a normal peripheral stain. But these dudes are showing up in the cytoplasm, and they're noticeable. So that's why it's called the large granulocytic leukemia. Those are also pretty large T cells compared to how they normally are sized. So this large granular leukemia is the one that likes to be positive for CD8. If it's the T cell cancer, I think this is the only CD8 positive T cell cancer in this SDL. If it is the NK phenotype, you see CD56 positivity. Finally, what do they want to ask you? Well, what's the gene and what's it do? The mutation in large granular leukemia, T or NK cell variant, is going to be a gain of function mutation in STAT3. What does STAT3 do? Well, it's a JAK activator, JAK, just another kinase. You guys know that, right? That's what it stands for, because the dude who discovered it was like, oh yeah, it's just another kinase. And it turned out to be a very important kinase, but he kind of tongue-in-cheek called it just another one. So also it's a cell cycle controller. There we go. That's what they really would love to. They want to make that C or maybe D. They want to put it down there so that you got to really know that it does the cell cycle. Because usually when people guess, they just say, "Oh, screw it." They go with A or B, you know. So they like to put the right answer very far down there in these cancer-related, gene-related questions. So it is related to cell cycle progression. There we go. That's what that STAT3 gene does. JAK protein, cell cycle. And in this particular cancer, it's constitutively active, leading to the emergence of a monoclonal population of cytotoxic T cells or NK cells. What is the patient most likely to get next? It's another style of question. Well, they could ask about an autoimmunity. Patients tend to get those. Or, again, infection. That's about all I got for this SDL. Pretty cool thing, though. Thanks a lot.